Hello, my name is Kratochvil. I'm a child and adolescent psychiatrist from the University of Nebraska Medical Center in Omaha, Nebraska. And the topic I'm going to be addressing today is diagnostic challenges in ADHD, differentiating ADHD from pediatric bipolar disorder. This is a list of my conflicts of interest, and the majority of the work we do is sponsored through the National Institute of Mental Health, but we do consulting with industry, work with designing clinical trials and conducting clinical trials as well. And also listed are some of the offices and editorial positions that I hold in different areas of pediatric psychopharmacology. So the things I'm going to address today are the clinical presentation and diagnostic criteria of ADHD. I'm then going to move on to the presentation and criteria for pediatric bipolar disorder, and then spend some time ferreting out how can we differentiate between ADHD and mood disorders when a child presents in our clinic. First of all, recognizing symptoms of ADHD. Now, many of us know ADHD is a neurodevelopmental disorder, meaning we often see this early on in development in children. So it's not surprising that we can see this presentation in the 4 to 6-year-old preschoolers. Now, often it won't be diagnosed and maybe won't treat it at this age unless it's severe, but certainly we often see symptoms. Now, if you look at the modal age of diagnosis of ADHD, it's about 8 years of age. But if you look at epidemiological samples of younger children, what they'll show you is that about 2% of 3 to 5-year-olds will actually meet criteria for ADHD. And if you look at the DSM, we actually see in the diagnostic criteria, they recognize this developmental aspect, requiring that symptoms present by 7 years of age. Now, certainly if we're going to be diagnosing ADHD at this young age, a clinician really has to have a good grasp of what's developmentally normal. Because obviously a preschooler is going to be very active, going to have difficulty focusing on things for much of a time. So when does it become abnormal, in fact, significant enough that it's causing impairment in their functioning? Now, when we're looking at the presentation of ADHD in a preschooler, some of the things we'll be looking for, again, are activities that are beyond the normal presentation of a preschooler. So, for example, extraordinarily hyperactive, accidental injuries. These are the kids who may be darting out in front of traffic or climbing out windows onto roofs and getting hurt. And certainly there's been evidence of higher rates of ER visits in kids with ADHD. These children will not uncommonly have difficulty maintaining in a daycare center with babysitters. They often end up, their families are having to avoid going to settings where kids need to have some restraint and some composure. And so it can really be stressful for the families as well as the children. Now, many of us are much more familiar with the school-age children, kind of the 6 to 12-year-olds who present as easily distracted, a lot of the academic difficulties, peer difficulties, trouble waiting their turn in games, out of their seat, and often viewed as immature by their peers. And then, of course, the adolescents. We have a much better recognition now of the fact that ADHD often progresses into adolescence and even young adulthood and adulthood. But what we can see in the adolescents is that it may be they start outgrowing some of the hyperactivity. So some of the adolescents, rather than projecting the overt hyperactivity, will instead have more of an inner restlessness. And in fact, this can be a pretty tough time because they're struggling with a lot of transitions, the transitions from grade school to middle school to high school, times when there are much more expectations that they are accountable for things, accountable for getting their assignments in, for showing up to things on time, things like that. This is also a time that we have concerns of risky behavior. Adolescents have much more opportunity to get in trouble, I guess, if you would, as far as driving, sexual activity, drugs, things like that. Certainly things we want to ask about and take into account in the assessment. And also many of these kids have poor self-esteem, struggle with peers, and struggle with authority. So how about making a diagnosis of ADHD? Now, it's important that we explain to our patients that making a diagnosis of ADHD is really a clinical process. Unfortunately, there's not a blood test or a brain scan to make this diagnosis for us. It's really good clinical skills, being able to systematically assess a child. And it's often helpful to have several informants. By getting feedback from the schools, from the parents, from the child, it can often give us a more global image of what's going on in their life. Now, one of the things that can be useful is using rating scales and different assessment scales to help collect data. And also, many of the rating scales are normed. So we can look and see, how does this score in this 6-year-old boy compare to other 6-year-old boys? And they're often normed by gender as well as by age. Now, a few I've cited here, for example, like Keith Connor's scales have certainly been around the longest, really the largest group of very well-validated norm scales. The ADHD-4 rating scale is a nice one because if you purchase it, you can actually make photocopies for your clinic and give it to trainees. The Vanderbilt assessment scale at nichq.org, that's one that's public domain, free access. So that's nice in screening both for ADHD but also comorbidities. And not only screening, but also tracking kids longitudinally. So once we clinch the diagnosis and we have a treatment, we can follow the kids throughout treatment and see how they do. Moving into the adult realm, the Adult ADHD Self-Report Scale. This is a scale that's, again, public domain, and looking at the diagnostic criteria as they may present in an adult. The American Academy of Pediatrics has a very nice toolkit they've assembled. This can be accessed at aap.com, at the American Academy of Pediatrics website, which really has wonderful tools for clinicians in practice, looking at diagnosis, treatment, information for parents, resources both for parents as well as practice management in dealing with the diagnosis and treatment of kids with ADHD. But in the end, what we need to do is always keep in mind reviewing the diagnostic criteria, because these are really what help us clinch the diagnosis of ADHD. The fact that these children have an onset by 7 years of age, although that criteria may change with DSM-5, it's certainly something we want to look at. Is this a longitudinal disorder? Did it present by 7 years of age, and has it been there at least 6 months? Is it causing global impairment? And then 6 of 9 inattentive symptoms and or 6 of 9 hyperactive impulsive symptoms. Now, I'm not going to go through all these diagnostic criteria, but I think it's really important in doing the assessment that we do systematically go through all 18 of the inattentive and the hyperactive impulsive symptoms. And they're certainly difficult to remember. Every time I do it, I have a list in front of me that I'll systematically go through and ask questions and collect information on the child. Now, when we look at the subtype, certainly the most common subtype is going to be the combined subtype. 50 to 60% of youth will meet criteria for that. Hyperactive impulsive is only 10%, whereas predominantly inattentive is right in the middle, about 30 to 40%. Now we'll see this shift in adolescence and adulthood, where we may have more of a shift to the primarily inattentive subtype. Now, certainly one of the key tasks for us as clinicians is what's going to be in the differential diagnosis and how are we going to differentiate ADHD from other disorders. Because as we see, there are many psychiatric disorders as well as general medical disorders that can mimic ADHD. And a lot of folks don't think about this, but depression, for example. Certainly 2 of the diagnostic symptoms of depression are poor concentration and psychomotor changes, either activation or slowing. So we may have a child who presents with psychomotor activation and poor concentration, and we're going to have to ferret through, is this anxiety, is this depression, is it ADHD, is it bipolar disorder, by looking at all the diagnostic criteria. Recognition of symptoms of pediatric bipolar disorder. Now, the presentation of bipolar disorder does have many similarities to ADHD, but also has some unique aspects that helps us to differentiate between the two. Now, in general, when we're looking at a youth with bipolar disorder, this is when we can see manic outbursts and really strong affective storms, grandiosity, flight of ideas, spending sprees, a lot of things to the extreme, maybe hyper-religiosity, maybe hypersexuality, rage, just pop bottle rocket explosivity with irritability and these temper tantrums. And these are normal temper tantrum. This may be something that will last for hours, these rage episodes, often with very little provocation. Very frequent mood swings, hyperactivity, decreased need for sleep, risk-taking, and low self-esteem. So you see there's several things there that do overlap with ADHD, but also several more unique issues. Now, when we come to assessment, a good diagnostic assessment really is crucial, and in part because if we look just at irritability, for example, it can be a multitude of different things. And certainly the treatment we select is going to be very different depending on what the etiology is. So, for example, if the irritability is depression, we may be treating it with an antidepressant and SSRI. If the irritability is due to bipolar disorder, adding the antidepressant may worsen things. Similar for ADHD and bipolar disorder. So again, being familiar with the diagnostic criteria is very important. And I have contained here the criteria for a manic episode. And I'm going to review these briefly because I think a lot of times folks may not take the time to really go through the entire list. And I know it's something that I catch myself skimping on sometimes, so I'll force you all to listen to the symptoms as well. So one thing is criteria A, a distinct period of abnormally and persistently elevated, expansive, or irritable mood for at least a week. Now, it may not have to be a full week if they get hospitalized, but otherwise, without intervention, there's that criteria for a week. So kind of a very unique, discrete period. Additionally, during the time of the mood disturbance, 3 or more symptoms that go along with it. Now, if it's the high, elevated, expansive mood, they only need 3 symptoms. But if it's just irritability, they need 4 symptoms. And of these symptoms, there are 7. Inflated self-esteem or grandiosity, decreased need for sleep, more talkative or pressured talking. They're talking so quickly you can't interrupt. They keep going and going and going, and you can't even get a word in edgewise. Flight of ideas, distractibility, increased goal-directed activity, and excessive involvement in pleasurable activities. So each of these are things that we're going to want to be looking for in diagnosing a manic episode. And one of the things that makes it difficult, as I've alluded to as we've been going along, is that many of the symptoms of mania may overlap. And that's what this chart really shows, is what is the overlap with mania and symptoms of depression, ADHD, oppositional defiant disorder, and anxiety disorder. So, for example, irritability, as I mentioned. We often see that in pediatric patients with bipolar disorder, but also children with depressive disorder, about 2/3 will present with irritability as well. In fact, if you look at the DSM-4 criteria for major depressive disorder, that's a caveat there in diagnosing depression in kids. It may present as irritability rather than depression. We also see a low frustration tolerance in ADHD, easily annoyed with ODD, and irritability with anxiety. Distractibility, hyperactivity, again, a couple of the cardinal symptoms that we see with ADHD, but we also see with anxiety. Flight of ideas, we can see that in children who have communication disorders that often go along with ADHD. So it may be that they have trouble expressing themselves, trouble explaining things, so it looks like flight of ideas, not keeping thoughts together. Certainly the poor judgment of mania may look like impulsivity of ADHD. And certainly sleep problems are something we see with a lot of the psychiatric disorders. With major depression, we often see insomnia or hypersomnia. With ADHD, we very frequently see sleep disturbances where kids have difficulty falling asleep and get up early and don't get adequate sleep. And certainly children with anxiety disorders often have initial insomnia because of the worries. So what are some ways that we can differentiate ADHD from pediatric bipolar disorder? Well, these are some slides that were put together by Dr. Catherine Gallanter while she was at Columbia, and I think they do a nice job of helping to differentiate how many of the symptoms present a little bit different with the two disorders. So, for example, euphoria. Children with ADHD may get silly, it may be transient, it's not going to be a big deal, it's rarely impairing. Whereas the bipolar kids, it really gets to be outrageous behavior, just completely over the top. Grandiosity, we may see a child with ADHD bragging. Often they're trying to boost their self-esteem or just trying to look better in front of their peers. Children with a manic episode, on the other hand, truly believe these things. They truly believe they can coach better than the coach of the high school, and they ought to be taking over for the coach and maybe playing college ball even though they're a 5th or 6th grader. Decreased need for sleep. As I mentioned, many kids with ADHD do have sleep disturbances, but oftentimes that's a longitudinal process that's really always been there for these kids. It's not a change from usual. And if we do see a change from usual, it's often because a medication's been added, maybe a stimulant that's causing some initial insomnia. Now, on the other hand, children with manic episodes, they may sleep only 2 or 3 hours and be fully rested. And what we'll see is it's a significant change from baseline, a couple hours or more change from what they usually would be sleeping. Racing thoughts. So you may have a child with ADHD who has a low IQ or a communication problem, so it may look like they're not expressing themselves well. But with bipolar, it can really be tough to follow these kids, to see where they're going because they're jumping around so much. And they'll go off on a tangent, then they'll go off on another tangent, then go off on another tangent, and end completely different place than they initially started. Increased goal-directed activity. Now with ADHD, as many of you know, these kids are often chronically hyperactive, and they're doing a lot of things, may not be all that productive, but they're very busy. Children with bipolar may get involved in very elaborate schemes, have surges of activity where they're working vigorously on something, and they may actually even be accomplishing some things, but also it may be that they're just spending a lot of time on things as well. The pressured speech. Certainly we see a lot of talking with kids with ADHD, kind of a chronic motor mouth. Again, with bipolar disorder, it can be more the pressured speech, and it's also often a change from what we usually see. So again, highlighting the episodic nature of the manic episodes. And the increase in pleasurable activities with potential for painful consequences. Now with ADHD, I really like how this is described. And what Dr. Gallanter described as is the mouth and or body engaging before the frontal lobe does. So they're just impulsively making a decision to do something because it sounds fun and going on with it. Whereas with bipolar disorder, it can be way beyond societal norms. And they don't take the time eventually to figure out that, gee, maybe I shouldn't be doing this. Because in their mind, they may feel they're entitled to do it, or they may feel there's nothing wrong with it. So what you see is that there can be a lot of different kids with many manic symptoms, particularly the irritability and rages, but things we want to look for are clear cycles of the mood, changes in this episodic nature. Also, is there a family history? And we'll talk more about that in a minute. We often see that this may be tracking in families with both manic depressive disorders and mood disorders in general. And is there a severe mood dysregulation, just completely explosive and off the chart? So as far as family history, this is something we always want to look out for, because what we see is if there's one parent with bipolar disorder, that child is 5 times at risk of developing a bipolar disorder. So it sounds like, gee, this is something we obviously need to be aware of, but the kid's really at risk, right? Well, remember, bipolar disorder only occurs in about 1% of the population. So what that means, if they have a 5 times the risk, that means about 5% of the kids who have a parent with bipolar disorder will develop bipolar disorder. So it's not like the writing's on the wall, this kid's definitely going to be bipolar, but certainly something we want to be aware of and look out for. Now, if parents, grandparents, aunts, uncles, siblings have bipolar disorder, that's probably clinically meaningful. If it gets much beyond that, second and third cousins, probably isn't a good predictor. The other thing is, just because there's not a family history doesn't mean that it may not be juvenile bipolar disorder. It may be that this is just the first in the family to develop it, or it may be the first in the family that's ever actually been identified. here is a few key things from an article that was in Child and Adolescent Psychiatric Clinics just a couple months ago. Things to consider in looking at ADHD and bipolar disorder. And one thing is to keep the base rates of the disorder in mind. Common things happen commonly, and we know ADHD is a relatively common disorder. So even though bipolar may be more common than we had originally thought, clearly ADHD is much more common. So if we're playing the odds, a child who presents with some of these clusters of symptoms, odds are it's ADHD. So, keep that in mind. Conservative estimates of ADHD are 4 to 7% in school-age children. A CDC report that was issued a couple of years ago said about 8% of 4 to 17-year-olds in the U.S. have been diagnosed with ADHD, so it's quite common. Whereas if you look in the adult bipolar disorder, it's probably about 1% and a little bit less than that in adolescents, even less than that in the younger children. Another key issue is to conduct a thorough diagnostic interview with the child as well as the guardian. Again, these are kids who are impulsive, they act without thinking, they're grandiose, they may not be good historians, but we still want to get that information from the kid, not only in making that diagnosis, but also in looking what else may be going along with it, what other comorbidities may be there, and also helping in the differential of nailing that diagnosis. So one of the first things to look for is there that extremely elevated expansive mood? Because if that's there, then it's very likely bipolar disorder. If it's not there, then we'll look for the irritability and things like that. But we're also going to be looking for a lot more things going along with it. So if it's just the irritability, is it more severe than a baseline? And are there those other things going along with it? The B symptoms in that criteria that I talked about, particularly the ones that aren't shared with ADHD. Irritability, not specific for bipolar. In fact, one of Barbara Geller's studies showed that 72% of the kids with ADHD had irritability. So significantly common with ADHD. But what Barbara Geller has also shown is that if you find the symptoms of elation, grandiosity, flight of ideas, decreased need for sleep, hypersexuality, then the scale is going to be tipping much more over into the pediatric bipolar realm. Another thing is using rating scales. I mentioned using the rating scales for ADHD. There's similar scales for pediatric bipolar disorder. The Young Mania rating scale is one that's commonly used. Additionally, life mood charts. And this is something that at dballiance.org, you can actually download for free these life mood charts. And many clinicians find this useful in working with the parents in tracking longitudinally what have these episodes been like with the child, when is it euphoric, when is it depressive, and really seeing how it develops over time and throughout the treatment then if a diagnosis is made. Now the rating scales do a much better job of ruling out bipolar than ruling in. Because if these rating scales don't have any symptoms, it's very unlikely they have bipolar disorder. Now, if they do have a lot of positives, then we're going to have to ferret out really where does it fall in that differential. Clearly very important to have a thorough evaluation. And not only to differentiate between the ADHD or the bipolar disorder, but as I mentioned, many times these kids have a comorbidity. Now, many of you have probably seen a similar slide. This is from the MTA study, the Multimodal Treatment of ADHD study. And what this demonstrated is that 69% of the kids in this study of 579 elementary school-age kids with ADHD had a comorbidity. Only 31% had ADHD alone. So often ADHD has something along with it. Similarly, bipolar disorder often has something along with it. So if you nail the diagnosis, you're confident it's ADHD and or bipolar disorder, what else may be going along with it? So comorbidities are really the rule rather than the exception with these disorders. And it's important to identify it because depending on what's going along with it, the comorbidity can impact the outcome of the child. The level of impairment, their response to treatments will significantly be impacted by what co-travelers are there along with that disorder. And in fact, it may require several treatments to address the specific target symptoms. So obviously, we as clinicians are going to have to be thinking through what are the potential medication interactions, what are the psychosocial treatments we can implement to address multiple different aspects as well. So in conclusion, just a couple of points. One, ADHD is very common. Two, bipolar disorder is much less common. When it is present, it's often comorbid with ADHD. So if you do identify bipolar disorder, often ADHD is there. So ferreting out that can be difficult. There is an overlap, but clearly, with a careful assessment, we can differentiate the two, and then certainly put the children in much better opportunity of responding to the treatment and better long-term outcome. Thank you very much for your attention.